Hi, this is Tom Shannon. I'm going to talk a little bit more about prostate cancer, and what I'd like to talk about is knowing your disease. If you've just been diagnosed with prostate cancer, it's an important thing to get a handle on what your disease is actually like. As you would have seen in the previous presentation, not all prostate cancers are the same, and they're not all going to behave the same way. So if you're facing prostate cancer, you're going to have to make some choices about treatment, and the first step in choosing a treatment is to get a good idea of what your disease is like and what your risk is. In order to do that, we look at grade and stage in prostate cancer. The grade is something we've touched on earlier with Gleason grade, which tells us how aggressive the disease is, and the stage really tells us how much cancer you've got. And that assigns a risk and allows us to individualise treatment choices. So just to recap on grade, it's the Gleason grading system using low-powered microscopy. A low-grade cancer still looks like normal prostate cells. A higher-grade cancer does not. You look at two areas, add them together, get a score out of 10. So looking again at the picture we saw in the previous presentation, a 1 is very close to normal looking glandular tissue, 2 a little less so, 3 starting to get more bizarre, 4s and 5s really don't look at all like the normal tissue and therefore have a much more aggressive biological nature. I'll touch a little more on the difference between 3s and 4s. As you saw in the previous presentation, almost 40% of what we see are Gleason 7s, and it's important to understand they're not all the same as well. Some Gleason 7s have got a lot of 4, and some Gleason 7s have got a lot of 3, and you can imagine that one that's got a lot of 4 is going to behave a lot differently to one that's mainly a 3. So because of that, in Gleason grade 7s, the amount of the higher grade 4 really determines a risk. So a 10% grade 4 Gleason 7 is much less aggressive than what we call a 4 plus 3 Gleason 7, which may be 80% grade 4. And it's important to know from your urologist, if you have a Gleason 7, exactly what you've got. In terms of stage, we're really looking at the volume and the location of the cancer. When you talk about the prostate itself, the vast majority these days are T1, where you can feel no lump, and your prostate cancer was only picked up because you had the blood test done. T2, you can feel a lump, but it still feels confined to the prostate. With T3s, it can feel irregular, and this suggests that the disease might be starting to grow outside of the prostate. Your urologist will use an A, B and a C with these as well, with A typically being less disease than the B, and which is less than the C. So if we look at that in a diagrammatic fashion, you can see at the top, stage 1, that's a T1C, where you see that small yellow dot in the prostate sitting under the bladder. It's a very small, early detected prostate cancer, usually of lower grade. Stage 2, you're starting to see a bigger tumour, it's been there longer, and that may be a slow-growing tumour that's been there a long time, or it might be a more aggressive tumour that's been there a short time. Once we get into stage 3s and 4s, you can see the problem that we face in being able to remove them completely. So the stage again says how much cancer is present. Stage 1 and 2, up at the top, are highly curable. Some stage 3 are curable as well. Some of them are completely removable or can be cured with radiotherapy. The 1s and 2s are the ones that we like to get as surgeons and are the best candidates for an operation. We also look at lymph nodes, which can be assessed by CT and MRI. Lymph nodes are like the gland in your neck that you can feel when you have a sore throat. You have them throughout the body, and they're next to the prostate as well, and we can see them on a CT or an MRI if they're enlarged. The bones can be assessed by a bone scan, but we don't normally do that unless there is a concern that there could be spread. So you should know from your urologist what your grade and stage is. For example, you should know whether it's a Gleason 7, and if it is, whether it's a 3 plus 4 or 4 plus 3, and what percentage of grade 4 you have. The stage may be given a designation such as T1C, which means detected only by PSA testing. And neurologists use this information to assign a risk, and following on from that, a plan would be made for treatment. And decisions regarding surgery and radiotherapy and the types that would be used, whether we're able to spare the nerves that supply the erections, whether we're able to preserve the bladder neck, which might reduce the time to getting incontinence sorted out. Another tool that we use sometimes is a nomogram, and a nomogram is a type of computer program which tries to predict what's going to happen to you after treatment, but to tell you that before you make your decision. Now, these aren't 100% accurate, and you must look at them together with information from your doctor. But by looking at your PSA level, your type of disease, and your stage of your disease, then you can get a decent chance of knowing how well you will manage with surgery or various radiotherapy treatments. These are available online at nomograms.org. So I'm going to stop there, and the next presentation is the look at what we can do about the prostate cancer from here.